Panel number 5, Public Policy, Resource Allocation Challenges in Health. The panel is going to be chaired by Dr. Andrea Yearwood, yet another person who was mentored by Professor Carl Theodore. Dr. Henry Bailey, and you heard this morning from him that he was also mentored by Prof. Carl Theodore. So too for Julian Prescott, so too for Professor Hari Harawan, Sita Raman, and so too for Dr. Christine Laptis. So this is an entire panel consisting of persons who have been influenced in a very, very direct way by our honorary Professor Carl Theodore. So I now hand you over to our chair, Dr. Andrea Yearwood.
Good afternoon, ladies and gentlemen. Thank you very much, Martin. And I am really very happy to be part of this panel of esteemed academics who have been mentored by Professor Carl Theodore. Our first speaker this afternoon is Dr. Henry Bailey, and he's going to speak to us on measuring health outcomes in Trinidad and Tobago. Now, there's quite a bit Henry would really like me to tell you about himself, including the fact that he actually was born in the Amazon and raised by Amazon women, 6 feet Amazon women. But I would allow him to tell you about his upbringing one-on-one. What I would tell you, however, is that he currently works at the Arthur Lockjack School of Business, where he lectures in economics. He also does one day, he's committed to health economics, and does one day also at the HU as a research associate. He is a peer reviewer for 4A journals, economic journals, and he's the founding member of the Global Health Delivery Network at the Harvard University. His research interest is in health outcomes and entrepreneurship and development. So I now hand you over to Henry to speak to us on measuring health outcomes in Trinidad and Tobago.
Okay, great. So thank you for that. There were 1 or 2 inconsistencies, but I only have 15 minutes, so I can't dwell on that. So my presentation today is not, instead of presenting one study or one piece of work, is to present an overview of work in health outcomes that we've done. The reason I asked the reviewers to allow me to present an overview rather than a paper is that Prof. Theodore, who is not here, has been a very keen supporter of this kind of work. So just as a bit of background, many of the things that have been discussed over the past day and a half resonate with this work in health outcomes. This work involves a set of instruments that provide the evidence for many of the issues that we have in health, issues relating to scarcity. So I've heard people touch on gender issues. We have data that actually shows what the gender differences are in health. I've heard people talk about equity. We have data that shows how health is distributed among the population. I've heard people talk about unmet need, about the need for certain services. We can give data to all of these studies. So the principal aim of what I've been working on in collaboration with others is to find measures where with a single measure we can capture how sick a person is. That's the basic idea of what we're doing. And there are some really cool approaches to that kind of thing. One is this instrument called EQ5D, the Eurocall instrument, where we break health status down into 5 dimensions: a person's ability to walk, their ability to care for themselves, to dress and take basic care of themselves, their ability to work, go to school, and do things, family things that we'd put under usual activities, and 2 experiential dimensions: the amount of pain and discomfort that they feel, and the amount of anxiety or depression that that they experience or that they see. So each of these dimensions in this instrument has 3 levels. A level which has no problems, a level which has moderate problems, and a level which has extreme problems. This is the full. So this simple tool allows us to describe any patient who is in any state of health or illness. I'll give you an example. If I pick this combination, this in the EQ5D language would be state 2, 1, 2, 3, 2. I don't have a pointer, sorry, but you can see that that is the order of levels in my 5 dimensions. So if we can understand, oh great, thank you. I get an extra minute for that. He stopped me to correct me. So if we could, right, great. So 2, 1, 2, 3, 2. So if we could understand the value that a citizen or a patient places on being in this state, and we can understand the value that they would place on being in full health, then in theory, if we could find somebody like this and cure them, we can have an understanding of the value of that cure to that patient, which is really a great thing to have if we're talking about equity and resource allocation in health. So the challenge has been to develop these value sets. The thing is, if you have 3 levels in 5 dimensions, you have 243 possible combinations. And what we started doing in Trinidad, we started looking at small sample, low-cost ways of finding these values. The state of the art of doing this in 2005, 2006 was to use huge samples, 3,000 people, and use very, very complex valuation tasks, and then we do the usual regression and find it. What we were doing here was trying to find a way to use this in the Caribbean. We didn't have the budget to get, we don't have online panels, we don't have online people. So we're really at a disadvantage. We needed to find ways of working with hundreds of respondents to develop these value sets. And that's what we did. We did some pioneering work in using choice-based methods and using discrete choice experiments to develop these value sets. I just lost my timer. Okay, so right. Got it back, right. So this is just an idea of how we would apply it. So we know that once we use choice-based methods for the elicitation, then everything that we do after that can be assumed to possess the von Neumann-Morgenstern utility properties. This allows us to do cost-utility analysis using values that are local, that are from Trinidad and Tobago. So I have just an overview of recent and current work that we have with this. We've done 3 valuation studies in Trinidad. The reason we had to do 3 was that we were doing kind of cutting-edge work. We were taking these small sample methods. We did one here that failed completely, but we learned a lot from that. We did a second one where some of the people who were involved in that are here in the room. Rani, Don, Dwayne were very supportive. They helped with the data collection and so on. We used offices that we borrowed from Dr. Mohammed and others and so on. And then we did further refinements of the method until we got it to the point where we could go to the ministry, ask them to fund a valuation study, which they did, and which we've just completed, and which we're writing up now. We also, I've been presenting this idea at every medical conference in the Caribbean where I could go. So through that effort, we have attracted other researchers who are now using this tool to do their clinical and their health economic analyses. So this is the valuation studies that I mentioned. I wouldn't go into this in the interest of time, but just believe me that we did a set of pilots. Okay. There's an idea of what the thing looks like. This is a Bayesian approach to selecting, because we have 243 states for which we need values, and we want a simple valuation task. What we do is give the respondent pairs of states and ask them to pick the one that they think is worse, or pick the one that they think is better. That's all they have to do. But the design of the experiment, this list here, is where a lot of the complexity is. We use some mathematical methods to pick the most efficient set of pairs that will allow us to do the analysis that we want to do afterwards. And then when we collect these choices, we use logistic regression methods to identify the betas. These are coefficients that will allow us to then give a value for every state from 1, 1, 1, 1, 1 to 3, 3, 3, 3, 3. Yeah? So that's enough of valuation. I say we've just finished the final one. We have a great protocol. We are ready now to implement this in other Caribbean islands. So we have a really good deal in terms of what the cost of this thing would be. For some applications, I've done a population health study where we took a representative sample of over 2,000 adults, and we had some interesting findings from that. First of all, this is the frequency of reported problems on any EQ5D dimension broken out by RHA. So it seems that the Tobago RHA, the people in Tobago are the healthiest people in Trinidad and Tobago in terms of reporting problems, any problems on the EQ5D instrument. The least healthy population seems to be Northwest, which is where I live. So this is not very good news. Looking at this here gives us the health status value by age group, and this follows international patterns. Obviously, as we age, our health declines a little bit, somewhat. I just pulled these out of the, this is where we talk about equity and gender and so on. Here we have actual data on these differences. Look at the difference between Southwest RHA and Northwest RHA. This may look small, but it's three VAS points is actually is big enough, and it's statistically significant. So we do have a difference between South and North RHA. Male and female, we have a difference of 2 VAS points. It is significantly different. So there is indeed, this is evidence that there is indeed a difference. It's not talk, it's actual, women are at a disadvantage. When we take tertiary versus primary, this is the highest level of schooling. Again, we see a much bigger difference, 4.3, and that is significantly different. When we compare people who have insurance, I heard somebody talking this morning about using private healthcare when you have to pay for it. And indeed, intervention thresholds are higher when people don't have health insurance. That's known. And we see that there is a difference between the insured and the uninsured on the private side, and that is significant. When we look at the difference between Afro and Indo-Trinidadian, it's a very small difference and is not significant. So that's good. And also, in terms of income groups, we found one difference between 2 income groups, which is these 2. The other income groups don't have. In fact, very wealthy people reported to be sicker than people who were moderately wealthy. Yeah? So maybe we could look at, maybe there's an age distribution or some third factor that is bringing that about. This is another area of how we can apply this. If we have 2 populations and we can ask them, we give them a form to fill out. Do you have problems walking about? Do you have problems with self-care? That's 5 simple questions. We can develop a schedule of all of the EQ5D states. This is some work that I did with Christine Latiste, where we took a population of dialysis patients and we took a matching cohort from the general public. And we were able to obtain values to show the difference in health in one number between these 2 groups of patients. Some other applications, well, this is the paper that we're writing up now. I was just waiting for the evaluation paper to be published, and we could then publish this one. We've worked out the cost per quality of dialysis to be less than $2,000 US, for transplant, which is a really, really good deal. That's consistent with international findings, and is good value for money. Here's a paper. Sanchez is Prof. Tilak Singh's MD student, and we're doing a different kind of renal study where instead of taking a matching cohort for the transplant patients, she actually has 140 transplant patients. So we're going to use EQ5D along with a renal instrument and do a comparison of that. This is a study, a diabetic foot study that we have going on. We're just writing up the ethical application now. Prof. Sampio from Yale, Vijay Narayan Singh, Prof. Narayan Singh, and we're looking at cultural tolerance. What they're interested in knowing is there a difference in the difference between a group of patients that has a diabetic foot ulcer and a diabetic patient that does not have this complication? Is there a difference in the difference between that population in the US and that population in Trinidad? EQ5D is perfect for that kind of work. We have two populations, particularly with serious comorbidity, and you want to tease out one effect from another. It's great. We just finished a major piece of work on health and entrepreneurship, where we're looking at the differences in health between people who decide to open their own businesses in the Caribbean and those who do not, or those who have an idea for a business and don't act on it. And there are significant health differences between these two groups. The decision to go into one's own business is tremendously enhanced with a higher level of health. More importantly, the quality of entrepreneurship has a very strong relationship with the health of the individual. A healthy entrepreneur is more likely to have certain properties in his business that make it more suitable for diversification and economic development than an entrepreneur who is not well. An entrepreneur who is replicative is more likely to have certain health issues than one who is not. There's a really, really long reason for that my chairperson wouldn't allow me to talk about. This is the model. How much time do I have, Andrea? 2 minutes, perfect, okay. So this is the health model of Wrightville. I hooked up with these guys at Erasmus because they have written extensively on this, and we produced the paper together. I wouldn't go into the findings. This is just more in detail of what I had said earlier. The last thing I'm going to show is an activity that we're going to begin now, and my colleague Gabrielle is in the audience here. We're working on this together, where we're giving policymakers and clinicians a set of tools, a tool to do great things. We're hearing a lot of great discussion about evidence-based medicine, about the methods, about the economic evaluation, about prioritization in health. But when you look at the literature of other countries that have made that leap, the process is very often very traumatic. There are certain factors or certain things that need to happen in society, in the clinical community, among policymakers, to have people ready, to have people engaged for things like explicit prioritization and evidence-based medicine. We don't know if we have these things in place. So we're designing a study now where we're going to look at 3 key stakeholders: clinicians, administrations, and the public, to see, are people really ready to have that conversation that we had this morning about who will get what in health. And many people are still living with a blinkered vision that I could go to Port of Spain General and get anything I need to get for free. That's not true. Decisions have to be made about what services are going to be provided to whom. And I think there's value in committing some resources to understanding the orientation and the attitudes and the perceptions of key stakeholders about the use of instruments like this. So I'm done. Thank you. Thank you. Yeah.